Hello everyone, my name is Dr. Jack McNulty, officially John P. McNulty, and I'm delighted to be able to share my insight and experience in discussing a topic which is sorely needed in palliative and end-of-life care. We will begin with these attributes: empathy, which all of us should have, the warm appreciation and recognition of another's suffering, walking in the other person's shoes. And compassion is what drives the desire to help someone in need. And finally, gratification, which to me is an important component. It is the emotional reward that one receives from helping. It leads to a greater sense of self-worth. It makes you feel better. It makes you want to do more to help. So we begin with probably the most difficult conversation, breaking bad news. And there is a 6-step protocol called SPIKES, which leads one through this protocol. And, you know, it is the responsibility of the doctor to break bad news. And over the past 2 generations, in the teaching of physicians and nurses, that ability to take that responsibility and follow through has not been as good as it should. Of course, everyone dislikes breaking bad news. Death and dying are something that we try to avoid, but doctors have that responsibility. First, set up the interview. Come prepared for the meeting. Know something about this patient so that you can lead the conversation. Be sure to have some privacy, soft lighting. Introduce yourself to whomever is there. Meet and greet everyone. By making eye contact and using a warm voice tone wherein you are respectful and relaxed is the first way to begin a relationship with that patient and family. Find out what they know. Ask, what did the doctor tell you about your condition? How much has he shared with you? This is important to know because it allows you how to proceed. If they already know what's going on, it's a simpler issue. And then you want to find out if that patient wants to know. In some cultures, the patient will defer to another family member, a daughter, a son, a spouse. And if that is so, and the patient really doesn't want to know, then you excuse the patient and continue the discussion with the responsible family member. And then you get to breaking the news gently, with empathy, honestly. Stop talking, please, during that emotional reaction to the bad news, because you have no idea how those people in the room are going to react. So stop talking, let it simmer down, and then when they are able to pay attention to you, begin planning the next steps, whether tests or referrals or further consultation is needed. And then, lastly and importantly, support. Tell them that you are going to continue to support them as this process goes on. Let me discuss a relationship in any difficult conversation pertaining to a nurse, a social worker, a chaplain, anyone. You need to introduce yourself. You meet and greet each person. You show you care by your voice tone, eye contact, body language. Be respectful. Sit down. take your time, listen to their concern and their problems, and then when you've understood their problem, repeat it back to be sure you understand and to let them know that you got their message. And then you explain and in a dialogue what you can about the problem issues using open-ended questions so that you are able to have a discussion without creating a barrier or a difficult situation. And then you want to hopefully help them make a decision or reach a settlement if there is one is needed. And if no resolution, you suggest another conversation, or you suggest a time-based trial if it's appropriate. Very important to establish a relationship in which you help them know that you care and that you are on their side. You don't want to establish barriers by the wrong attitude or approach. As much as 93% of communication includes nonverbal behaviors. I don't know if you've read Blink, the bestseller by Malcolm Gladwell, in which he talks about how the brain recognizes visual and auditory stimuli responding in the blink of an eye, faster than we can think. And he describes experiments showing that a patient meeting a doctor or nurse will react well or badly with their first glance. And he even described studies in which a warm voice tone, even with the words garbled, expressing empathy and caring, are liked by patients and families in conversations with doctors. Among the other thoughts that are contributing to establishing a relationship, trust. Trust is an essential ingredient to resolving any dilemma, helped by understanding and cooperation by the parties involved. Trust must be earned. It's not always a quick process. In speaking with the patient's family or their representative or surrogate, please don't ask, "What do you want for Mama?" Ask, "What would Mama want for herself?" Tell me more about Mama and her life before her illness. This will get you off on a good start where you don't throw up a barrier. Please don't try to answer specifically the situation if you allow them to tell them, "Do everything for Mama." Deflect or divert the conversation. And then finally, help patients decide. Years ago, when I was in my early career, we used what was called a paternalistic approach, one in which we knew so much more about the patient's condition that it was important that we helped guide the patient as to what to do. And then the pendulum swung away from paternalism, and I recall being very upset about the decisions of, say, an oncologist who, in giving a patient a bad diagnosis and coming to a conclusion about what to do about it, would offer options to the patient and have them decide and not participate actively in the decision. I thought that was inappropriate. And now the pendulum has swung back to working together, where we work together as a palliative or hospice team, palliative team really, because this is when the decisions are made to change from curing to caring aspects of treatment. And I think that helping them decide by working together is a proper and ethical way to help patients. Find out what issues concern the patient and family. Include the family in your caring team. Help them understand. And you need to say this over and over again, that hospice helps people live comfortably until they die. And it's necessary for every member of the team to mention and teach that morphine does not hasten death. It allows comfort, relief of pain and shortness of breath, and in some cases helps patients live longer in comfort. Much evidence-based literature has proven that morphine does not hasten death. Let's now discuss some specific dilemmas, those that we encounter commonly and that are difficult and can, if improperly done, establish a barrier, a wall between the physician and the treating team and the patient and family. Let's begin with the patient saying to the physician, "Doc, I want you to help me die." And how do you react to that? If you're a young physician with little or no experience in dealing with issues like this, you may very well feel very uncomfortable. You may say something like, "Oh, I'm sorry, I can't morally, ethically, or legally help you." And that physician is uncomfortable and he wants to leave that room as quickly as he can, and he misses a great opportunity to help. If only he had said, "Help me understand. Tell me more. Why do you feel this way? Tell me your story." It is possible for you to make a plan. That patient may be very depressed and hasn't had any attempt to treat it. That patient may be in really bad pain and no one has been able to help. And believe me, helping someone with intractable or severe pain is something that we can do very well. And, you know, many people want to commit suicide in an instinctive, emotional reaction to something in their life, and that those who survive that emotional attempt at suicide, 80% never try again. And so you want to be able to step in and at least attempt. Now, I will grant you that there will be patients who want to die and intend to die, and even with your best efforts, you may not be able to help that. But that doesn't mean that you shouldn't try. Another common dilemma. The family says, "Do everything possible for Mama. We want everything done." Please try to deflect or divert this. Please don't try to answer that question without having done something like this. "Please tell me more about Mama. Tell me about Mama, but before her illness began. You love Mama. The more I know about Mama, the better I can help her. And so let's have a conversation about that and try to avoid throwing up that barrier or conceding that you are going to do everything possible, which in this case may be inappropriate, very inappropriate, and lead to prolonging death, creating increased suffering, and it's all because the family is emotionally involved and doesn't know enough about her condition to make a reasonable logical decision. Another one that we frequently confront: do you mean Daddy will starve to death without a feeding tube or IV fluids? Please don't answer that directly. Again, ask him to tell you more about Daddy. What happened in the hospital? What led to him being in the hospital? And how did they treat him? That Daddy may be full of fluids. He may be stuffed with IV fluids, and it would be harmful to do so. If he's in a stage of the journey to death where he is no longer interested in eating or drinking, and death is within a few days, a feeding tube is inappropriate. You can educate them about the complications of feeding tubes and the inefficient use of a feeding tube, or the complications that will result. And every once in a while, if a patient is in hospice and the family is adamant about fluids, and it is not a situation where you will harm the patient, you may compromise. You may compromise because if you don't compromise, the patient won't enter hospice and won't get good care. And if you give IV fluids as a therapeutic trial, you might say, well, let's try some fluids and see if this helps. Would you agree that in 3 or 4 days, that if he's getting worse, that he's not responding, wouldn't it be reasonable to stop those because he's on a journey that his death is imminent, and you appeal to their ability to reach a reasonable decision? Not always easy. You may have to have conversations more than once. What about when the family says to you emphatically, no morphine, no morphine? Again, you want to know why. It may be that that patient is allergic to morphine or has had an adverse effect from morphine, and that's fine. You substitute something else. If it's because they have a bias, a prejudice, or has a myth about how patients go into hospice, they give them morphine and the patient dies. It's education, the ability to get through to families about morphine is the most important medicine that we have at the end of life. And you educate them why. And you substitute another drug if they're hung up on no morphine, because they deserve to get relief from the suffering that they have. Another one that we often hear: don't tell Mama she's in hospice, or don't tell Mama that she's going to die. Most of the time, Mama knows that she's going to die. She may not have been told that she's in hospice, but she really should be, because hospice represents a standard of care, and that she'll be much more comfortable. But that's a conversation that takes a little time and developing a relationship so that you find out, if possible, from Mama what she knows, preferably when the family's not hovering around, because it's very possible that Mama knows that she's in hospice or knows that she's going to die and wants to protect the family. I recall an instance a few months ago when this husband and wife The wife knew that she was dying of cancer. She didn't want the husband to know. The husband knew that she was going to die of cancer, but he didn't want the mama, his wife, to know. And the social worker was having a difficult time until she told the husband that Mama knew, and Mama was protecting him, and that he was protecting her. And she said, "Why don't you go in and have a conversation?" And that was one of the most wonderful conversations when they together were honest with each other. And they sobbed and hugged, and the rest of her life was one in which peace was present, and they had a good death. Really important to try to get them to confront the elephant in the room. Another dilemma: stop the pain meds. We want to talk to him. That's a reasonable request. Sometimes the pain meds are sedating, and they want to talk to him so that they can say their goodbyes or be able to discuss whatever's necessary. So instead of completely stopping the meds, where withdrawal symptoms might develop, if it's pain might get seriously ill, discuss the options where you can tell them, let us stop the meds and let the blood level of the opioid drop, so that when he's able to talk, if he's pain-free, fine. But if he needs the medicine, we can reduce the dose, or we can change the pain medicine so that they can talk and he has relief. Again, you've got to have a conversation in which they are willing to listen, and the technique is in gently explaining how you can accomplish their needs. Another one that we get occasionally is, why can't Daddy stay in the hospital if he's dying? You know, families are really afraid of death. They're afraid of taking him home and going through the ordeal of him dying there, whereas most patients want to die at home. Now, there are situations in the hospital where the patient is so close to death that the mere transportation of him might cause him to die without proper attention. And so if that's the case, he stays in the hospital. But if he's within a week or 2 or 3 or whatever, it's not us who wants to move him, it's Medicare or the insurance company or the hospital. So you explain that there are issues that we have no control over, but we agree completely, if he's close to death, that he can stay there. And finally, the care he gets at home may be more appropriate and better if he's in hospice, where this team of individuals is going to give him what has been proven to be superior care at the end of life. And then finally, don't stop Mama's medicines. I did some research about 3 years ago looking at the medicines that are on the patient's record when they enter hospice. The average is somewhere between 11 and 13. And some of those medicines were prescribed years ago under different circumstances. And they may very well be inappropriate, they may be harmful. And that patient or that family will say, well, Dr. Jones said, ma'am, you're going to have to take this medicine for the rest of your life. And Mama believed him. And it sometimes is difficult to persuade the patient's family and the patient that this medicine is no longer appropriate. And in our study, we were able to reduce the medicines by being able to show them that they were inappropriate, they were harmful, they were duplicates, they were treating something that she no longer had. And so we were able to successfully demonstrate that paying attention to Mama's medicines, you can answer that situation very appropriately. One of the problems we face when we are dealing with difficult situations, a patient who is having a progressive downhill course, is the issue of futility. Why do people request futile treatments? They have unrealistic goals. They experience feelings of guilt. They may mistrust physicians. They may get a mixed message from physicians. Or they differ culturally and socioeconomically from the treating team. They may deny the prognosis. They may not want to understand that this is a situation we have no control over. Death is coming. And then finally, if they have a language barrier, we can't communicate well with them. And frequently we need, especially in hospital practice, that we get someone who speaks that language to help translate and be helpful. This is an article by Hanratty about patients' perceptions upon receiving bad news. Basically, what it says is when the patients knew the doctor already, they accepted the bad news more easily without as much suspicion or distrust. They did appreciate the pace and clarity when a setup and gradual interview buildup was used when the doctor was new to them, such as if you are seeing the oncologist for the first time and he is going to break the bad news. So the setup that we discussed, the 6-step program, is good in one situation, isn't as necessary when they know the doctor. Everybody agrees that a family member was essential to be present. You can imagine if someone is by themselves and is told something, their life is flashing before them, their thoughts are chaotic, they might remember much of what was said. One group of patients seldom received specific knowledge, and that was heart failure patients, in which it was most often specialty nurses, not the cardiologist, breaking the bad news. And that's changing. There has been an effort on the part of the cardiology community to help them become more familiar and more comfortable with breaking bad news and knowing when to change the protocol from curing to caring. One of the important things that the interdisciplinary team can do is explain the dying process to families who often don't know what to expect. And education of the family allows them to understand how we can achieve a natural death, what we term a good death, as contrasted to a bad death. But I emphasize that this is what a natural death, the steps are the usual slow progressive decline in function, becomes less interested and then is not interested in food and fluid, talks less, sleeps more, is confused, finally coma, and then a peaceful death. That's what we all want. And let's contrast it to what we call a bad death, a difficult death, an unnatural death, in which the patient, for various reasons, is more confused, becomes agitated and restless, and hallucinates, and has pain or shortness of breath, and is obviously suffering despite all attempts to help. And that suffering is felt by the patient, the family, and the staff. Tell the family gently and honestly about his or her disease, and try to explain in minutes, hours, days, weeks, or months what is likely to happen if and when they want to know. Please remember, we are not good at prognosis, particularly at long-term prognosis. This article by Timothy Quill wants patients to answer these questions. What concerns you most about your illness? As you think about your illness, what is the best that might happen and what is the worst? What are your hopes for the future? What are your greatest fears? Being able to develop a conversation on these issues makes it possible for you to understand how best you can help them, and using all of the measures that you know to make that death a comfortable, natural one is what is to be desired.